To understand diabetes, we first look at the pancreas, a unique dual-function organ. While 99% of its mass is exocrine, secreting digestive enzymes via acini cells, we are interested in the endocrine portion. Within the islets of Langerhans, alpha cells secrete glucagon to raise blood sugar, while beta cells are responsible for secreting insulin and amylin. Insulin production is a highly regulated multi-step process. It begins at the ribosome, where mRNA is translated into pre-proinsulin. This is then cleaved in the endoplasmic reticulum to form proinsulin, consisting of A, B, and C chains. After final packaging in the Golgi apparatus, it is stored in secretory vesicles as mature insulin, zinc, and C-peptide. Clinically, measuring C-peptide is vital because it is secreted in a 1-to-1 ratio with endogenous insulin, helping us determine if a patient is still producing their own insulin.
How does the beta cell know when to release insulin? It starts with hyperglycemia. Glucose enters the cell via GLUT2 transporters in an insulin-independent manner. Inside, glucose undergoes glycolysis, generating ATP. This rise in ATP causes potassium, K+ channels to close, leading to membrane depolarization. This electrical change opens voltage-gated calcium, calcium 2+ channels, and the resulting influx of calcium triggers the exocytosis of insulin vesicles into the bloodstream. Once in the blood, insulin acts like a key. It binds to the alpha subunits of the tyrosine kinase receptor, the LOCK, on target cells. This binding causes the beta subunits to autophosphorylate, activating the intracellular PI3K-AKT pathway. This signaling cascade causes GLUT4 transporters to translocate to the cell membrane, effectively opening the gate for glucose to enter the cell. Insulin is the master hormone of the fed state, focused on storing excess energy. In the liver, it stimulates glycogenesis, storing glucose as glycogen. In skeletal muscle, it drives glucose and amino acid uptake for protein synthesis. In adipose tissue, it promotes lipogenesis. Crucially, insulin inhibits degradation pathways like gluconeogenesis and lipolysis to prevent the body from breaking down its energy stores when food is available. Think of blood sugar management as a metabolic seesaw. On one side, insulin, amylin, and incretins, like GLP-1, work to lower blood glucose. On the opposite side, glucagon and stress hormones like cortisol, epinephrine, and growth hormone work to raise it. The body constantly adjusts this balance to maintain euglycemia, typically between 80 to 120 milligrams per deciliter. The breakdown of this system happens in two primary ways. Type 1 diabetes is an autoimmune destruction of beta cells, leading to an absolute insulin deficiency. It typically presents in children. Type 2 diabetes involves peripheral insulin resistance, followed by beta cell exhaustion. This results in a relative deficiency and is most common in adults and overweight individuals, accounting for 90% of all cases. Patients with hyperglycemia often present with the 3 Ps: polyuria, frequent urination, polydipsia, excessive thirst, and polyphagia, hunger, along with blurry vision and slow-healing wounds. Conversely, hypoglycemia presents with dizziness, tachycardia, and shakiness. For hypoglycemia, remember the rule of 15. Consume 15 to 20 grams of simple carbs, wait 15 minutes, and recheck blood sugar. We monitor 3 main metrics: fasting blood glucose, target 80 to 120 milligrams per deciliter after 8 to 12 hours of fasting; postprandial glucose, target less than 140 milligrams per deciliter 2 hours after eating; and HbA1c. HbA1c provides a 2 to 3 month memory of average glucose levels, with a general clinical target of less than 7% to prevent long-term microvascular damage. Our goal with treatment is to mimic the physiological release of insulin. This requires basal insulin for background maintenance and bolus insulin to cover the sharp spikes in glucose that occur after breakfast, lunch, and dinner. Different insulins have different profiles. Rapid-acting, Aspart, Lispro, has a quick onset, less than 30 minutes, for meal coverage. Short-acting, regular, takes about 30 minutes. Intermediate, NPH, lasts 16 to 24 hours, while long-acting, Glargine, Detamir, provides a steady basal level for 24-plus hours with no peak. Remember, the peak action time is when the patient is at the highest risk for hypoglycemia. Insulin is administered subcutaneously, and injection sites must be rotated to prevent lipodystrophy, fat atrophy, or hypertrophy. Other side effects include weight gain due to insulin's anabolic nature and hypokalemia, as insulin drives potassium into cells, potentially depleting serum levels. In summary, healthy beta cells sense glucose and release insulin. In diabetes, either immune destruction, T1, or receptor resistance, T2, disrupts the lock and key mechanism, leaving glucose locked out of cells and leading to systemic hyperglycemia. We use exogenous basal bolus therapy to restart this process, aiming for an A1C of less than 7% to ensure long-term health. Thank you for joining us for this deep dive into insulin dynamics. If you found this structured clinical overview helpful, please like, share, and subscribe to CleanMed KE for more medical education content. See you in the next video.